This video will discuss diabetes insipidus. When does the features of diabetes insipidus develop? The features of diabetes insipidus develop when ADH secretion is reduced to less than 80% of the normal. And what's polyuria? A 24-hour urine is more than 50 ml per kg, and in a 70 kilogram man it's 3500 ml or 3.5 liters, and a urine osmolality is less than 300 milliosmoles per liter. The urine specific gravity is 1.01 to 1.005, and a urine is less concentrated than plasma, and a plasma osmolality is increased to more than 295 milliosmoles per kg, and there is hypernatremia and hypokalemia. So the serum sodium is high and the urine output is high, where the urine sodium is low and the ECF volume is reduced. What are the types of diabetes insipidus? There are 4 types of diabetes insipidus: central, number 2 nephrogenic diabetes insipidus, gestational, and primary polydipsia. Let's discuss central diabetes insipidus. The most common cause of central diabetes insipidus is idiopathic and occurs in 50% of cases. Trauma and surgery are also common causes. Congenital malformation, hypogenesis or ectopia, and midline craniofacial abnormalities also cause central diabetes insipidus. Amongst the genetic causes, it's an autosomal dominant disorder. And when does the feature develops? The feature develops several months to a year after birth and is due to selective degeneration of the magnocellular neurons. Autosomal recessive and X-linked can also occur. Amongst the other forms are trauma, tumors, and infection. Among the tumors, craniopharyngioma, adenoma, and meningioma can also cause diabetes insipidus. Amongst the infection, viral encephalitis and toxoplasmosis, and sarcoid, amyloid, and histiocytosis, and damage to the pituitary stalk can also cause diabetes insipidus. The central diabetes insipidus patient prefers ice cold water. What's the cause of seizure in diabetes insipidus? Dehydration and hypernatremia. What's Wolfram syndrome? Wolfram syndrome is a combination of different disorders along with diabetes insipidus. It includes diabetes insipidus, diabetes mellitus, optic atrophy, and neural deafness. The nephrogenic diabetes insipidus. There are 3 types of nephrogenic diabetes insipidus: genetic, acquired, or drug-induced. What's the cause of genetic nephrogenic diabetes insipidus? 90% of cases are due to X-linked recessive variety with mutation in the vasopressin 2 receptors. And when does it present? Unlike the genetic form of the central diabetic insipidus, the nephrogenic genetic form typically presents in infancy. Dehydration and hypernatremia can lead to seizures and mental retardation. The ureters are dilated due to high urine flow. And how the diagnosis is done: high plasma ADH with polyuria and hypotonic urine with hypernatremia. Autosomal dominant and autosomal recessive forms of nephrogenic diabetes insipidus are due to the mutation in the aquaporin 2 channels. The acquired forms of nephrogenic diabetes insipidus. What are the most common causes of acquired NDI? Hypercalcemia and lithium are the most common causes, lithium in 20% of cases. The other causes are renal tubular diseases, pyelonephritis, analgesic nephropathy, hypokalemia, amyloid, sarcoid, histiocytosis, and multiple myeloma, papillary necrosis, or osmotic diuresis. What are the drugs that cause nephrogenic diabetes insipidus? The mnemonics is MEAL, M-E-A-L, methoxyflurane, ethanol, amphotericin, and lithium. What are the antibiotics that cause nephrogenic diabetes insipidus? D-maclocycline, which is a tetracycline group, rifampin and aminoglycosides that include gentamicin and kanamycin. When does the nephrogenic diabetes occur in pregnancy and why does it occur? The nephrogenic diabetes in pregnancy occur in the second and third trimester of pregnancy and due to the increased production of vasopressinase, which is produced from the placenta and it destroys the ADH. Primary polydipsia or excessive water drinking. There are three types of primary polydipsia: dipsogenic polydipsia with increased thirst. Number two, psychogenic polydipsia where there is no increase in thirst. And number three is iatrogenic polydipsia. Dipsogenic polydipsia patients have increased thirst and is due to the fact that osmoreceptors are set at a low point. It causes a trauma tumor infection, and the drugs that cause dipsogenic form are lithium and carbamazepine. Multiple sclerosis may also cause dipsogenic polydipsia. The urine concentration in dipsogenic polydipsia is low because the kidney capacity to concentrate the urine is also blunted by chronic polyuria. In psychogenic polydipsia, there is no increase in thirst, and the disorder is due to psychosis, as in schizophrenia and obsessive compulsive disorders. The iatrogenic polydipsia is due to the drugs or health issues. So what are the clinical features in polydipsia? Slightly increased body water and decreased plasma osmolality, decreased ADH, and decreased urine concentration. Why fluid deprivation test is done? The fluid deprivation test is done to differentiate polydipsia from central and nephrogenic diabetes insipidus. See, after a fluid deprivation test in primary polydipsia, the urine osmolality goes up to more than 750 milliosmoles per liter, whereas in central and diabetic insipidus it doesn't change. How to distinguish between central and nephrogenic diabetes insipidus? After 1 to 2 hours, desmopressin increases urinary osmolality by at least 50% in CDI, but will not change in nephrogenic diabetes insipidus. So after the desmopressin injection, that neurogenic or the central diabetes osmolality is more than 800, whereas no change in nephrogenic diabetes insipidus. How is the MRI of pituitary in normal subjects and in diabetes insipidus? Posterior pituitary emits hyperintense or bright spots in normal subject and in primary polydipsia. Bright spot is absent or small in pituitary diabetes and in nephrogenic diabetes. Bright spots strongly suggest polydipsia and excludes pituitary diabetes. When is bright spot absent in normal subject? Bright spots may be absent in some normal subjects and in empty sella. What's the treatment of diabetes insipidus? Treatment for central diabetes insipidus is desmopressin or ADH. And the treatment for nephrogenic diabetes insipidus is hydrochlorothiazide combined with potassium sparing amiloride. Indomethacin may also act. So how does the thiazides act? The thiazides decrease the distal tubular reabsorption of sodium and water. So it decreases the GFR and increases the absorption of sodium and water in the proximal tubule. So thiazides decrease sodium and water reabsorption in the distal tubule and increase sodium and water reabsorption in the proximal tubule. So less fluid reaches the distal nephron, so overall fluid conservation is obtained.